Okay, so now we're ready to begin. So just before we start, I'm going to draw your attention to the little black Q&A icon for questions and answers. You should find that somewhere at the top or at the bottom of your screen. And anytime during this webinar, if you would like to ask a question to be addressed by our panelists later on in the session, you can type in a question by clicking on that icon. So without further ado, we're ready to get started. We will start. I'll introduce Jim Parks. He's our president, and he will make some opening remarks and get things started. So Jim, just a moment. I'm going to put you on the screen, and you have the floor now.
Okay, thanks, Tom. Hello, everyone. Welcome to our
Jeez.
annual supporters meeting. As Tom indicated, we have a full agenda. I'm making a few preliminary comments and don't want to take up valuable time for the later, more important things, including the financial report, the lecture, and the question and answer session, which are always the most highly anticipated part of the meetings. I don't want to say an awful lot about things other than to point out that I assume most people who have tuned in are familiar with the Society and its website and can dial in to get more detailed information about the Society. We send out newsletters, and you can sign up on the website at no cost to get on the mailing list to get newsletters, etc. We recently updated our website so it's more user-friendly, has more easily reached information about question and answers, and we have information for new patients who've just been diagnosed, and we hope that will be useful for them. Just a couple of comments Tom can flesh out later. We hold seminars, webinars, I should say, online. We had one in June. We're having another in November, generously sponsored by Thea Pharmacy, and dealing really with a my journey approach to things. And Tom can say more about that. From 30,000 feet, the society is a corporation without share capital and registered as a charity. So that means it doesn't have shareholders. It has a board and it has members. The only members are the directors, which streamlines things. It's regulated by the Canada Revenue Agency, files an annual return. It has audited financial statements. And the number of directors currently is fixed at 12, but there are 11 in office with one vacancy. The directors serve as volunteers, contribute their time generously with no monetary return. And the return is that we all feel good about what we do. So having said that, I'm going to put up some slides for each of the 11 directors. So Tom, if you can just do that, please.
Just a moment, Jim. I'm trying to advance the slide.
Okay.
I'm not sure I'm getting it right. Are you seeing it now? Yeah.
I'm
11 volunteers?
Yep,
Yes.
that's the
Okay.
first one.
All
Yeah.
right. I'm sorry. I was having trouble with the advancing the deck. Go ahead. Are you ready for the
Yep, I'm
introductions?
ready for the actual slides. So,
Okay.
okay, so that's yours truly. I'm the president, as I mentioned.
Sorry, Scott.
I'm a lawyer dealing in business law and a focus on charity and not-for-profit law and trusts and estates. So that's enough for me. Next up, Martin Chasen is our past president. Martin's an accountant who a couple of years ago was instrumental in changing our financial year from May 31 to December 31, which has really streamlined things and coordinated our financial reporting, fundraising, and process of issuing grants by the end of the year. Next up, please. There's Tom, who you already know from his introduction. Tom's a professional engineer and our treasurer, and we'll hear more from him later about financial matters. Next up is Dr. Mark Schaffer, who's our executive secretary. Mark's a family physician who was instrumental when we first started raising money through originally the Toronto Marathon, and more recently through our own Walk for Research, which is coming up next Sunday and about which you'll hear more shortly. Next up, please. Dr. Trope, I'm sure, is known to all of you. He's the chair of our Scientific Advisory Committee, a retired ophthalmologist and one of the worldwide experts, and fortunately for me, my former personal doctor. Next up, Dr. Katie Burt is an ophthalmologist at Sunnybrook Hospital. She's the vice chair of our Scientific Advisory Committee and has been very involved in the Canadian Glaucoma Society, of which she's a past president, and has been involved in a lot of our webinars and other endeavors. Next up, please. Dr. Raj Bendlish is also a glaucoma specialist, and he's been quite helpful in dealing with question and answers in our annual newsletters, which I mentioned, or I should have mentioned, go out twice a year, and is generally very productive in a lot of our outreach. Next up, please. Dr. Cindy Hutnick, another ophthalmologist associated with Toronto Western Hospital, and another past president of the Canadian Glaucoma Society. I'm sorry. Next up, please. Alf Quinter is a lawyer specializing in personal injury and brings a different perspective to the board in terms of not only the law, although he's not a business lawyer, but has been helpful in outreach and some of our business promotion with magazines and radio spots, etc. Next up, please. Scott Leslie is a business owner connected with the pharmacy industry and was critical in connecting us with some of the pharma companies, and in particular Thea Pharma, which is the sponsor of our webinar series. And you'll hear more about that later, as I just mentioned. And then finally, last but not least, Stuart Murray is an accountant who has been extremely helpful in upgrading our website, dealing with IT issues and social media, which of course is quite a hot topic these days. So that's your board of directors. And Tom will make some comments later in his report about the diversity and experience of our board. So each year we present certificates of appreciation to various supporters, and we're doing so again this year. The first one is to Thea Pharma Canada, which, as I mentioned, has generously sponsored our My Glaucoma Journey webinar series. We had one in June, and the next one is scheduled for November. Next up, Dr. Michael Ballas, who is very involved in the My Glaucoma Journey, a former presenter at the lecture, the Albert Waxer lecture in previous years, and a critical part of this webinar series presented by Thea. Next up, please. Wendy Younger, a certificate in appreciation of her generous financial contribution on behalf of her parents, Goldie and Stanley. Next up, please. Linda Martin, in recognition of her generous financial contribution. Next up, please. Jasmine Allen, associated with Gate West, for her generous financial contribution. Sally Mitchell for her generous contribution, both financially and in terms of moral support. As many of you may know, Sally's husband, Mel, was a former director who unfortunately passed away far too soon. And so we're wanting to present her with this appreciation, both for her personal contribution and in recognition of Mel's previous contribution. Next up, that's it for me. At this point, I'll return later to wrap things up, but now I'm going to turn things over to Tom for the treasurer's report, and he can then segue into the other parts of the meeting.
Okay, thank you very much, Jim. I'll take over for now. Let me see if I can put the spotlight on me. There we go. Hmm. So I hope that you can see the presentation deck. Jim, can you see the treasurer's report slide?
I see the slide. Yep.
Is it in full screen?
Yep.
Okay, good. All right. So, as Jim said, I'm the treasurer of the society. I joined in 2017. It's been a pleasure to work with this board. Um, okay, now I have to figure out how to advance the slide. There we go. Okay. So, this is a high-level summary of the diversity of experience that we have on the board of directors. If we start at the bottom of this picture, there's one engineer, that would be me. So I joined the board in 2017. I attended one of these annual supporters meetings, walked up to Dr. Trope and announced that I had just retired from my work. And he looked at me and he said, "Great timing. We need somebody on the board who understands computers, can help us with our office procedures and the like." And I signed up for a board position at that time. But it's a pleasure to work with this board because anytime we need anything relating to glaucoma or ophthalmology, we have an expert on staff who can answer those questions. If I work up from the bottom, we have Scott, who's a pharmacy business owner, recently retired, but he gives us any consulting advice that we need about the pharmaceutical industry. Anytime I have trouble with financial matters, because I did sign up to be treasurer, we have two accountants on the board who can answer any of our financial questions. Um, we have two lawyers on board. One is Jim Parks, who you heard from, and the other is Alf Quinter. So anytime we deal with wills and estates, contracts, insurance, matters of that sort, we have the expertise to deal with those issues. And then, of course, we have one general practitioner and four ophthalmologists. So we're well represented in the field of ophthalmology and medicine. So we have all the skills we need to run the society the way it needs to be run. Um, the next, I'd just like to have a shout out to our office administrator, Norlin Roberts, and congratulate her on her second anniversary with the society. I've known Norlin for over 20 years before she joined the society. She has extensive experience in office management and administration, and she's a member of the International Association for Administrative Professionals. Before I went out looking for administrative help, I didn't even know there was such a thing, but there is. And Norlin is a member in good standing and really understands the role and has been doing a great job for us for the last couple of years. Um, Moving right along, I wanted to give you a quick sense of what we do during the year. You may only hear from us a couple of times a year when we send out newsletters or we have a meeting like this, but the board and our office is busy 12 months of the year. So if I was to just start, let's just say we're sitting here, it's October 22nd. So I'm going to start just take a look at October. Here we are in October. We're holding the annual supporters meeting, and this Sunday we're holding our walk for research, where you can sponsor one of the participants who are walking. Many of our board members are walking a 5K walk for research, and we're raising money. It's one of our largest fundraising events of the year. And we're coming into the beginning of the very important part. If you look at November, we're opening the research portal. That means that we're ready to receive research proposals from hospital researchers and university researchers. And that's our main mission. Our main reason for existing is to fund research. So we're ready to receive, shortly, we'll be opening the portal and ready to receive proposals for next year's grants. We also have a My Glaucoma Journey webinar coming up. This is a new initiative sponsored by Thea Pharma to have doctors who receive new glaucoma patients to welcome them to a presentation that they can listen in on. We do that in the summer, in June or July, you'll see here, and one in November. This is a new initiative for 2025. In December, it's Christmas time, holiday time. We send out holiday cards to remind you that we're here. And we ask researchers to submit their proposals to the Society for evaluation by Christmas. If you move over to the beginning of January now, over here, that's when Norlin really gets busy because she has all of the research proposals in and she has to send them out to evaluators. The evaluators are doctors and former research grant recipients who evaluate and score the proposals against a measured criteria so that only the best proposals are the ones that stand first in line for funding. In February, we prepare all of our financial records, submit them to our auditors because we have to have audited financial statements as a nonprofit. So that keeps us busy in February. In March, we usually have a webinar to celebrate World Glaucoma Week that's put on by some of our researchers or ophthalmologists, and you'll get a notice about that in the spring. We have two newsletters a year here in April. We send out a spring newsletter to let you know what's going on. And there's another newsletter that goes out in the fall in September down here. In May, we get all the scores in and score the research proposals and figure out. It's my job as treasurer to figure out how much money we can award, how much money we have to award for grants, and the top scoring research proposals get funded for their and receive grants. In June, we send out the research grant. We do the process for getting all the contracts and documents signed for the researchers, and we send out the grant money for them. In the summer, we have our second Glaucoma Journey webinar, which is a new thing for the summer. In August, it's a little bit quieter. We sit back and plan the rest of the year and get the content ready for the fall newsletter that goes out in September. So that pretty much covers our activities for the year. You can see it's a very, very busy time for all of us during the year. If I look at the financial highlights for 2025, I guess I could say I have a mixed bag of news. I have the good news and bad news, I suppose, or not so good news. The good news is that over the last 5 years, we've awarded over $1.5 million in funding for glaucoma research in Canada. In 2023, I'll highlight that. In 2023 and in 2024, we had a very successful year. We had almost $400,000 a year that we gave out in grants, and we funded quite a large number of grants. The not so good news is that last year in 2025, we did not have, I would have to say, we did not have our best year. And on top of that, we were overwhelmed by the number of research proposals that we received. We received over 24 proposals for grant funding, and unfortunately, it was a year where we did not really exceed our previous years in revenues. So we were limited in how much we could provide in grants and how many grants that we were able to fund. We did fund 13 grants totaling almost $220,000. But we were disappointed that we couldn't fund more. So we are looking a little bit better this year. I think we're heading towards a much better year in 2026. So far, we've been on track for receiving an increase in funding over last year. We have our Walk for Research coming up, so we're optimistic that we will try to get back to the levels that we had in funding for 2024 and 2023. Okay, so with that, where does our money come from? Well, it comes from you, our supporters. We count on donations from our supporters, big and small. We do send out mailings in the spring and the fall, and our holiday New Year's, Christmas cards. And that's just a reminder that if you're so inclined to think of us during those times and see what we're doing in the newsletters, that you might consider sending in a donation, which we appreciate. All of our donations can come through the mail, although we have a mail strike, which is not good, but we can receive donations online anytime throughout the year. And online, you can also sign up for monthly donations, which we have many people just give a certain amount every month, which is great because we know that it's coming in every month. We also receive significant funding from wills and estates. So if you are thinking about looking at your will or doing some estate planning this year, if there's any chance that you could think of us in your will, we would be most grateful. If you wanted to give back and thanks to some of the ophthalmologists that have looked after you over the years, this is a great way to recognize them and provide support for research for the society. And finally, we have our 5K walk for research coming up this Sunday, and there's still plenty of time to go to our website. You can look at one of the banner screens, and it shows you how to donate to any of the board members and others that have joined our walk for research this year. Here's a slide that just shows you one of our past walk participants. We've already raised about $40,000 when you count the actual amount donated and pledged up to date. Our goal is to hit $60,000, which we did hit last year, and we hope to exceed that goal this year. So the annual walk for research is this Sunday, and you can find a way to donate on our website if you go to glaucomaresearch.ca. So with that, I'm going to turn the floor over to Dr. Trope, and he will introduce our speaker, Dr. Ellen Zhu. So if you give me a moment, no, I will try to, there we are. Dr. Trope, whoops, I'm sorry I have to find you. There you are. Okay. There you are. Can you hear us?
I,
Okay.
I
There you
can hear
are.
you okay.
Just a moment. I'm going to put this, I'm having a little trouble transitioning the slide deck. So I'm gonna, there. Okay. So the floor is yours, Dr. Trope.
Thank you very much, Tom. It really gives me great pleasure to introduce the 2025 Albert Waxer speaker, Dr. Ellen Zhou. Dr. Zhou has had a very interesting academic career so far. She obtained her high school diploma in China. She then came to Canada and in June of 2009 received a Bachelor of Science degree from McGill University from the Department of Biochemistry. This was followed by a Master of Science degree from the Department of Pharmacology, also at McGill University. She did so well that she obtained access to the MD program at McGill, and in 2019, she qualified with both an MD and a PhD from McGill University, a double doctorate. Her PhD thesis was on retinopathy of prematurity, which is a very important condition in premature babies, which can and does lead to blindness. She then decided she wanted to be an eye surgeon. So she joined the Department of Ophthalmology at the University of Montreal in Quebec, and then transferred to the University of Toronto, where she finished all of her training and qualified as an ophthalmic surgeon in June of 2024. If that wasn't enough, she then decided she wanted to be a glaucoma expert. So she decided to go to Halifax, where she spent a year at Dalhousie University training. They have a very good department there. And she finished her training in June of 2025 and was snapped up by Queen's University in August of this year and has been appointed an assistant professor in that department and a glaucoma specialist. So she's now based in Kingston. Dr. Zhu has really done remarkably well academically for somebody so relatively junior. She has published 25 articles in peer-reviewed journals, which is really very good. And she's obtained funding from us, from the Glaucoma Research Society of Canada, on 4 separate occasions, either as the PI, the main investigator, or co-investigator. Her current research is in conjunction with the PI, Dr. Matt Schlenker, who's going to be on the Q&A after her talk today. And the work that she's involved in with Dr. Schlenker is on glaucoma medicine, adherence, and persistence. I could carry on for another 20 minutes. I'm not going to do it. I'd like to just mention to you that the title of her talk is Keeping Sight, Insight, the Role of Medication Compliance in Glaucoma. And with that, we'll turn over to Dr. Ellen Zhu. Welcome, Ellen.
Thank you very much for the very kind introduction, Dr. Trope.
Okay.
So,
Ellen, just a moment. I'm going to stop sharing my slide and you can turn on your slide deck now.
yeah. Let me try here.
And I'm going to try to put you. I'm going to try to turn on your picture. There you go. All right, go ahead.
All right. Good evening, everyone. Is seeing the slides okay, Tom?
Yes, I see the full slide on the screen.
Okay, perfect. Well, first of all, thank you, Dr. Cho, for a very kind and warm introduction. And good evening, everyone. I'd like to thank first the Glaucoma Research Society of Canada for having me to present this project. It's a very nice study that's funded by this initiation. And most importantly, I would like to thank you, the sponsors and donors, and the audience sitting in front of computer in the evening for supporting glaucoma, and that enables us to find a better care and better solution for this disease. So as Dr. Tro had introduced, I basically, jump across different cities, and now I settled down in Kingston, working at Queen's University. So today we will talk about glaucoma medication compliance, which is a very important concept, an important way to keep glaucoma at bay. And I will divide our presentation into 3 parts. First, I will talk about what glaucoma is. followed by discussing glaucoma medication compliance and what we found and learned from our study. So first, let's take a look at glaucoma. So what is glaucoma? Well, it's a degenerative disease of the optic nerve, and optic nerve is the cable connecting the retina and the brain, transmitting signals in between. And glaucoma is an issue when we have high eye pressure or high intraocular pressure. The high IOP can lead to damage, irreversible damage of the optic nerve. So whatever that's lost to glaucoma can hardly be regained. The normal range of IOP is somewhere range between 8 to 21, and for a lot of glaucoma patients, they have IOP that's consistently higher than 21 and thereby leading to optic nerve damage. Glaucoma so far is a leading cause of blindness in the world. In 2020 to 20, there were 76 million patients in the world having glaucoma. And as the incidence rises as patient age, it is estimated by 2040, there will be 112 million patients. So if glaucoma is a very important disease, how can we know if someone has glaucoma or not? Well, sometimes it's not until late that we realize that someone has glaucoma, and then this person may have already lost a lot of vision. Because glaucoma is also known as the silent thief of sight, oftentimes when we have high pressure, its damage is very insidious and can be quite asymptomatic. And it really takes a comprehensive eye exam with an optometrist or ophthalmologist that you can catch glaucoma early. Then what are the methods to treat this disease? Well, there are 3 tricks up the sleeve of your ophthalmologist, and the main goal to treat glaucoma is to reduce eye pressure. In doing so, we can stop the progression of the disease and to preserve what's left. Once again, I want to stress the fact that optic nerve is composed with neurons, and these neurons can hardly be regenerated once the disease has impacted the optic nerve. So the first method to treat glaucoma are the eye drops. For those who have been using eye drops, you know there are different types of glaucoma eye drops. The second method are the lasers. For example, you can use SLT lasers to clean up or clear up the drainage system in your eyes. In doing so, the fluid in your eye can be drained more readily and the pressure can be lowered. Last but definitely not the least are the surgeries. In the last decade, there has been a rapid expansion of surgical intervention in glaucoma, different devices available, and has been a very interesting topic. And that's part of the reason why I get into this domain, this specialty in ophthalmology. So now we arrive at our first stop. We briefly discuss what is glaucoma. It's an insidious disease that can only be caught by a comprehensive eye exams. The incidence of glaucoma increases with age, and there are many ways to treat glaucoma: drops, laser, and surgery. And the goal is to stop disease progression. So secondly, let's talk about what is compliance and why is it important to treat in management of glaucoma. Well, compliance is a very important concept in medicine, not just in ophthalmology. It means to use a medication as it is intended to. And there's 2 elements in compliance: persistence and adherence. Persistence means to use a medication continuously, persistently, without stop. And adherence means to follow the prescribed regimen. So if there are 2 things within compliance, then there are 2 or 3 ways actually to be non-compliant to a medication. For example, you can be not persistent. For example, there are interruptions in your regimen, early termination of a certain medication. You can also be not adherent. For example, you miss a dose. If you need to take it 3 times a day, now you're taking it once a day or 2 times a day. There's one example of not adherent. Or you're taking it at a wrong dose or wrong way of administration. Instead of putting in the eye, somehow the eye drop missed the eyeball but stay on your skin. Medication compliance is so important because the consequences are very severe. As you can imagine, it can lead to poor disease control. If you have glaucoma or high blood pressure, Failure to adhere to the medication prescribed to you can lead to irreversible damage to the kidneys, your eyes, your nerves. Sometimes uncontrolled diabetes can lead to amputation. And the same idea applies to glaucoma. If you're not taking eye drops on a daily basis, your eye pressure can be too high or can fluctuate, and that can lead to irreversible damage to the optic nerve and blindness. And at a global level, if a lot of the patients are not compliant, and that can lead to things like stroke and heart attack requiring expensive interventions like surgery, bypass, heart stents, and etc. So it's a lot of burden to the healthcare system as well. There are a lot of reasons to be not compliant to your heart, diabetes medications, and so on, but there are certain barriers that are specific to glaucoma eye drops. First are the side effects. For those who are using the eye drops, you may appreciate that sometimes you experience itchiness, burning sensation, redness around your eyes, and your lash can just be growing and at the place that it should be and other at random places as well. So some of these symptoms are very bothersome to patients. Secondly, because it's a small bottle, they can be very difficult to use. A lot of patients find it difficult to aim something at your eyes. It's just so natural that you will shrink away. And more importantly, oftentimes as the disease affects a older generation, patient may have tremor or arthritis, making it even more difficult to use the drops. And on the third point, as glaucoma is very asymptomatic, missing drops sometimes you won't really experience the symptom immediately. And again, it's a silent thief of sight, and patients need to use it on a daily basis. This kind of repetitive long-term use make it very difficult for patient to follow, especially sometimes, life is busy and you have other things planned. And for our patients, when they also have a lot of comorbidities, high blood pressure, diabetes, arthritis, you name it, and adding a extra eye drop on top of 10 other medications that you're taking can be quite challenging. So these are the few barriers I can think of for our glaucoma patients. So we talk about that compliance is very important. And actually, what do we know about compliance? So that's why we carry this study, and I would like to share our data with you and what we learned from it. So far, what do we know about glaucoma medication compliance in Canada? In fact, not much. We don't have any new data available in the past decade in Canada. So the objective of this study is to investigate glaucoma medication persistence at the population level in Ontario. Again, there's two components within compliance. Persistence, meaning being consistently renewing a medication. Persistence and adherence. And adherence means to follow a specific regimen. So in this study, we specifically look at persistence. And because this is a population study, we would like to capture as many patients in the province as possible. And we collaborated with the Institute for Clinical Evaluative Science. It's a powerful, enormous database that has a large number of public health data. And this investigation is the first study to examine glaucoma medication persistence rate at a population level within a public-funded universal healthcare system, such as the one in Canada. And this is our amazing research team. We have PI Dr. Matthew Schlenker, who's our panelist here. We collaborated with Dr. Rosella, who is an epidemiologist. Jimmy, Mike, Marco, and I are the workforces that collect and analyze the data. And now I would like to share the data with you. So in the province of Ontario, we identified about 74,000 patients who were using glaucoma eye drops. Now, in this group, we further classify between a long-term user who presumably are glaucoma patients because they need to renew this medication quite a few times. And on the left side, we also identify short-term users who only renew this medication once or twice. And you may wonder, why do we need a short-term glaucoma medication? Well, because glaucoma medication lowers eye drop, and sometimes procedures like cataract surgery can transiently increased eye pressure. So sometimes you may be using glaucoma eye drop just for a short period of time, especially during a post-op period for the cataract surgery. Okay, so let's look at the long-term user here who are presumably glaucoma patients. We then classify them based on their persistence level. No persistence, partial persistence, and full persistence. Now, I would like to say that for the goal of glaucoma treatment, the only right answer for full persistence is 100%. Now, in your mind, I would like you to guess what the full persistence number here is. It 90%, 50, 30, or 10? So think about a number, and I'm going to show you I'm going to show you the data. And here it is. Well, within our long-term users, possible glaucoma patients, 37% of them have no persistence. And 34.5% of them have partial persistence on and off. And only 28.5% of these patients achieve full persistence. And this is really bad. Less than 1/3 of patients are fully persistent. Then we also look into the factors that are associated with full persistence. And here are the factors we identified. These patients tend to be female, tend to have a family doctor, tend not to have multiple comorbidities or multiple disease like diabetes, high blood pressure, dementia, etc. These patients tend to have a higher socioeconomic status. And interestingly, these patients tend to have a history of recent hospitalization. And this is a rather interesting observation from us. And we think that it's probably because when a patient is admitted to the hospital, from your electronic record, that the hospital doctor can see that you are using an eye drop, and they may renew your eye drop had you forget to use it. And in doing so, encourage the persistent use or continuous use of the medication. So female, family doctor, no multiple comorbidities, high socioeconomic status are good factors. So what have we learned from this study? Well, we learned that on one side, we have different things that are associated with, that contribute to medication non-compliance, things too expensive, too many medication to juggle, no family doctor. And there are things that are helpful to achieve better compliance, such as forming a good habit of medication use and teaming up with your family doctor and ophthalmologist. And what have I learned from this study as an ophthalmologist? And what I learned here is that, and also from things I learned as a resident and fellow, is I try to renew and try to review glaucoma medication with my patients during each visit. I will ask if they're compliant and what kind of difficulties and challenge they are facing when they're using the medications. Then at the end of the visit, I will give them a new prescription or fax it to the pharmacy, making sure that they have more than enough renewals. I also give them verbal encouragement, saying that you're doing a great job and that's why your pressure is so great, because I want them to feel empowered as they are managing their glaucomas in their own hands. Now, sometimes I do have patients feeling very difficult to use eye drops and their pressure is not optimal. So I will think about my next step to do laser or surgery. So some of my patients ask me, well, forming a habit is very difficult. Can you just give me some tips? Well, my first advice is to make it obvious. Put your glaucoma eye drop somewhere that you can see and you can reach, and just couple it with a habit that you have on a daily basis. For example, you have green tea or coffee in the morning, then you can put your bottle right next to it. So whenever you make your coffee, you can put your morning dosage. Some medications are used at night, then you can put it on your nightstand right next to your book. So whenever you close your book cover, then you remember it's time for your eye drop. And by association, this will encourage continuous use of the medication. Now, I know many of you are using more than one medications or eye drops. Then make it easy to remember. For example, using iPhones or Androids, you can set up the alarm clocks. Or if you're a paper person, you can also use calendars or checklists to help you remember. And lastly, glaucoma medication compliance or in general compliance is a teamwork. Talk to your ophthalmologist, talk to your glaucoma specialist or ophthalmologist, ask them questions and encourage us to renew or remind us to renew the medication if you're running low. So to summarize, glaucoma is a neurodegenerative disease of the optic nerve that's caused by high eye pressure for a very long time. The disease often runs an insidious course and takes annual eye exam to catch it. And the goal of glaucoma treatment is to stop disease progression. As we've seen, compliance to glaucoma medication is a huge issue. And from our data in Ontario, only 28% of patients achieve full persistence within in 2-year period. And we identify some key factors associated with full persistence as well. And last but not the least is that glaucoma medication compliance takes a teamwork from patient, physician, and also the healthcare system who needs to optimize the pricing and the availability of the medication as well. So at the end, I would like to thank your time, your listening to my presentation. Once again, I would like to thank Glaucoma Research Society of Canada for your support, and I'm happy to take some questions as well.
Okay. Dr. Zhu, that was terrific. You did a great job. Thank you so much. If you could stop sharing your screen. There you are. Okay, congratulations. Well done on that presentation. I'm sure that you will get a number of questions and in our Q&A session. So just a moment. Where's my mouse? Okay. All right. So we're going to start our live question and answer session now. Just remember that during the session, you can look for the black Q&A picture at the top or the bottom of your screen and submit questions. Our panelists, our question and answer panel consists of Dr. Zhu, Dr. Katie Burt, Dr. Cindy Hutnick, and Matt Schlenker, who worked with Dr. Zhu on her research. So without further ado, I will just simply bring up our panel. Just a moment, please. Okay. Okay, Katie, you can turn on your microphone.
I think I have already.
Okay, just a moment. And now here comes Dr. Hutnick. You can turn on your microphone. Here's just a moment. I'll get this right. Here's Dr. Schlenker. You can turn on your microphone now, and there we are. There's Dr. Zhu. Okay, you're good to go. Katie, take it away.
Thank you very much. It's a pleasure to be asked to moderate this Q&A session. We've had a nice number of pre-submitted questions, and we're starting to get some on the Q&A. I can't promise we'll get them all answered, but any that we don't get to are likely to turn up in the Q&A section in our newsletters. So if we don't get to your question, keep an eye out there, please. I'm going to ask the questions that have come through and invite one of the other panelists to answer, or answer it myself, perhaps. And we'll try and get through as many as we can. So, Matt, I'm going to give you the first one. This is a question from someone who says they have advanced open-angle glaucoma and will likely need cataract surgery in the next year or two. Should it be done by an ophthalmologist who's experiencing cataract surgery or a glaucoma specialist because of the risk of spikes in pressures with surgery? Is there option for combination?
Thanks, Katie, and thank you to whomever gave that question. I think this is a question that perhaps comes up for other people, and it's really exciting to see such great patient engagement as well on glaucoma. I suspect, the patients most concerned about glaucoma. Not everyone is. And that's one of the factors of why people, for instance, don't take their drops, as Dr. Zhu just eloquently described. To answer this question, I think that, many years ago, glaucoma specialists didn't do a lot of cataract surgery. So the answer may have been make sure, especially if you have a type of glaucoma that leads to cataract surgery complications, such as pseudoexfoliation, the answer may have been go to an experienced cataract surgeon. But this has gone full 360 at this point because glaucoma surgeons are trained to do cataract surgery, and we have many procedures now that are synergistic with cataract surgery. So I am sometimes disappointed to see that someone quickly got their cataract surgery done while they had significant drop burden, which they may or may not be taking, maybe a 28% chance that they were fully taking if we look at Ontario Health System's data. Or they may be experiencing some of the other issues with them, cost, irritation from the drops, sometimes though rare systemic side effects. So cataract surgery is really an opportunity to have someone experienced with dealing with small pupils or ligaments that are not very secure, and also combining potentially with a procedure that can stabilize the glaucoma. And this is also in the spirit of trying to prevent us from doing larger glaucoma surgeries, which carry more risks. Another side point here was this question of eye pressure spikes post-cataract surgery, and it's absolutely more prevalent if you have pre-existing glaucoma, your outflow system is not working well, two-hit hypothesis, and the eye pressure goes up. Just as an example, one of the microshunts that we use is called the Hydrus microshunt. There was a 5-year randomized control trial where they compared cataract surgery alone to cataract with the microshunt, and they analyzed that data for eye pressure spikes. And what they found is that 1.4% of the patients who received the cataract surgery in the Hydrus had a spike, which is obviously not ideal, but the other group had 14%. So it was quite a difference in the eye pressure spike rate, and that likely speaks to some additional drainage from the microstent that was implanted during cataract surgery.
Super, thanks. It's a complicated topic, and I'm sure you could talk for another hour just on that. But we'll move on a little bit now. I have a question about drop side effects for Ellen. Is it normal to have eye bags or small, red, swollen, puffy patches just around the corner of the eyes from taking drops? And is there anything one can do about this?
Great question. As I mentioned, a lot of glaucoma drops has side effects, and periocular skin change is definitely one of them, especially for those prostaglandin analogs. So your question, is it common to have eye bag, redness? It could be related to eye drops. Sometimes eye bag can also be a side effect of being older and wiser. So that's part of the reason as well. But in terms of itchiness, redness, and burning sensation, and all these symptoms are most likely related to the medication. And someone asked me a question on the Q&A typing there. Sometimes I advise my patient to put the bottle in the fridge, and sometimes it helps with the coldness, helps to reduce the symptom. But if this symptom or this side effects have been persistent, even for the redness, the tearing or burning sensation, it might be a good idea to phone your ophthalmologist, and it might be a good opportunity to switch up the drops, or even, if you're allergic to a lot of medications, as Dr. Schlenker mentioned, should consider using a surgery with a better safety profile like mix.
Thanks. Cindy, there's a question here about research in the role of heredity in glaucoma and research being done in this area.
Okay, well, thank you for that, Katie, and good evening, everybody. When we talk about the family history of being a risk factor, the first thing to understand about risk factors is it doesn't necessarily you're going to get the disease. It just means that you have something about you that may put you at increased risk compared to someone who doesn't. So for a while, probably about 10 years ago, there was quite a bit of research going on looking for a genetic link, like what within your genes is putting you at risk compared to someone else. And a lot of research was done, and people started noticing that the genes seem to be scattered throughout what's called the genome, all of your DNA. The one gene that kept coming up was called the gene that codes for a protein named myocillin, but even then, the one that was most frequently associated was found to only account maybe for about 4% of all glaucomas. So I think, unfortunately, perhaps what the genetic research has shown is it's not as simple as other diseases like cystic fibrosis, where having a gene that is directly transmitted will actually allow you to almost predict whether someone within the family will have it. So when it comes to glaucoma, it's complicated. And I think if you ask all of the ophthalmologists on the panel, we probably think that there's many different types of glaucomas, meaning that it's not a single disease with a single entity, and therefore it's not really a disease that's linked to a specific gene. So unfortunately, we don't really know what the genetic transmission is. There hasn't been really much progress in that type of research over the last 10 years. So like most things about glaucoma, it's complicated.
It certainly is. There's a question on the chat here asking about being misdiagnosed with glaucoma. Again, this is something that could be easily an hour's discussion. I'm just going to say that unfortunately, it is sometimes difficult to diagnose glaucoma. We often refer to people as glaucoma suspect, meaning that they have some features that might be glaucoma, but it's not yet reached the point where we truly want to recommend treatment. And sometimes it takes time to see whether the situation is stable or progressive to really decide whether there's a true diagnosis of glaucoma or simply some factors that mimic glaucoma in some effects. So that's a very short way of saying it depends. But we look at the pressure, we look at the function of the eye with the visual field, we look at the nerve at the back of the eye, and trying to put a gestalt together to decide whether this is a diagnosis of glaucoma that needs treatment or a situation that needs monitoring, or occasionally decide that someone is actually just fine and doesn't need us. So Matt, I'm going to ask you a question about comorbidities or two problems. If someone who has a retinal problem such as lattice degeneration, plus a family history of glaucoma, so there's the genetics again, could the lattice degeneration get worse if they are diagnosed with glaucoma in the future?
Okay, lattice degeneration is a fairly common disease that we mostly see in people who have large eyes and are nearsighted. I think the simple answer is it's not necessarily related to glaucoma itself, though people who are nearsighted are more likely in general to have glaucoma, and it's a little bit harder to diagnose the glaucoma in patients who are nearsighted. So I think having lattice degeneration is a marker that you should continue to get assessments with your ophthalmologist, possibly your retina specialist, and possibly a glaucoma specialist. And also of note that when you have a cataract surgery and lattice degeneration, you have a slightly higher risk of having a retinal problem.
Yeah, these complicated things often need several different people's input. Ellen, there's been several questions about eye drops and with some emphasis on the fact that drops are occasionally hard to get. So someone who is on a brand name has been asked to use a generic. Someone who's on preservative-free has been asked to use drops with preservative. Do you have any comments in terms of, is this an acceptable substitution or could there be side effects?
Yeah. So to address the first question, the first point is there any side effect? Well, basically, sometimes what's confusing for patient is that the medication, when it's brand name, generic name, the names are very confusing to start with. So sometimes even the pharmacist may give the wrong bottle. So someone mentioned that he was using Compigan and he now switched to only Alphagan because we know Compigan has two molecules and Alphagan is only one molecule. So in my practice, whenever I got a letter saying that certain medication is back order, I will phone the pharmacy or fax to pharmacy to make sure that the substitution it has the same molecule of the original bottle. And again, as I mentioned in my presentation, it's always a teamwork between the patient, the pharmacist, ophthalmologist, and GP. So for me, I just try my best to make sure my office dealing with these medication related questions prudently, because sometimes pharmacists, they do make small mistakes like that. And sometimes when the patient switch from one bottle to another bottle, maybe the second medication sometimes for whatever reason is a little bit less effective, I will have them to come in a little bit sooner to check their pressure as well.
Thank you. Cindy, we have a question about yoga, and I know you've had some interest in the topic, and also about the risk or the benefits of lower body and core exercises. And is there a possibility of it worsening intraocular pressure?
Well, thank you for that question. And I'm actually pleased to hear that we have some of our patients who are doing exercising. In the case of hot yoga, yes, Katie, I have been doing this for over 10 years. So I have some personal experience when it comes to the pranayama, the breath holding, as well as the alternate nasal breathing. The thing about it, whenever we are straining, we're either holding our breath or we're doing things that we tend to hold our breath while we're doing, such as lifting heavy weights. Even a very tight blink of the eye can cause our eye pressures to spike quite high, but it tends to be only momentary. So I know with pranayama and yoga breathing, we do hold our breath for a while, but it generally tends not to be more than, I would say, about 20, 30 seconds. Now, for the average patient, we have compensatory mechanisms where the pressure will come back down after those spikes, and it really will not cause much harm. So it would only be under the extreme of conditions if someone had really advanced glaucoma, and maybe if during those yoga sessions they're doing a lot of head below the heart, that can actually put the patient at risk. We know the benefits, the health-related quality of life benefits of yoga are very extreme and high, very beneficial for patients. So my advice is that doing yoga is good for you. It's generally good for your health. If you have a qualified yoga instructor, you can, from my experience, ask them if they have any suggestions to modify what you're doing. But even then, we don't know what the credentials of your yoga instructor are. So I would suggest always going to your eye care professional, running it by them, having them explain to you the stage of your glaucoma, and if indeed they think the breath holding is putting you at risk. But in general, doing yoga is a good thing. And really just make sure you run it by your eye care professional to make sure they think it's okay for you.
Thanks. There was a question about if laser and surgery can cure the disease, why still use eye drops? And then there was another question that came in later from someone else asking about the long-term use of drops. I think the core message I would give here is that we don't cure glaucoma. So one way or another, the eye pressure has to be controlled because that is our only treatment. But it may not be necessary to use drops all your life if we replace the control with something like a successful laser or a surgery. Laser effects tend to wear off over time, so might need to be repeated. Surgery can last an awful long time. A really good surgery can last the rest of someone's life, but it's by no means guaranteed, even with the best of surgical hands. Eyes sometimes don't take the surgery as well as we'd like. So one way or another, if you have glaucoma, you're going to need treatment long term. So this next question, Matt, is about some of the newer surgeries. Trabeculectomies were the gold standard for many, many years, but now there are newer, less invasive procedures. Can you tell us a little bit about them, please?
Sure. So trabeculectomy has been around for a long time, and I think there's a reason it's been around a long time, and it doesn't seem like it's necessarily going anywhere. And what's happened though is we have more trade-offs to make between the various options. So a trabeculectomy may work the best in the long term, but can have some more uncertainty and issues in the short term. And then you have to have a discussion with your clinician of whether this suits you best. For patients who've already had a trabeculectomy, if it starts to not work well, sometimes our approach, and again, it depends on the situation, is as Dr. Burt just alluded to, is medications and using them together with the existing surgery. Other times we'll do lasers, and sometimes we'll go and release the scar tissue from the trabeculectomy, which in some ways is the first minimally invasive glaucoma surgery. We can do it actually in our clinic, and it does not require suturing or opening up tissues. Having a trabeculectomy, though, does not also preclude you from some of the other newer technologies, and they can be considered if the trabeculectomy is inadequate.
Thank you. It's again a big topic. I'm going to combine two questions here a little bit for you, Ellen, please. Someone was mentioning that they have normal pressure or low pressure glaucoma, but they continue to have glaucoma vision loss. And someone else asked about research on people who get glaucoma under 50. So these are two smaller subcategories.
Mhm. Yeah. So as I mentioned, glaucoma incidence tend to increases with age. And indeed, like in our study, most patients are 65 and above. There are indeed patients who can have early glaucoma under 50, or even, we know there are juvenile forms of glaucoma, people born with glaucoma. So in general, when patients have glaucoma at a younger age, they tend to have some genetic predisposition, as Dr. Hunnick mentioned. They tend to have a heavier family history. Sometimes glaucoma can be due to persistent eye inflammation. So for patient younger with glaucoma, glaucoma may not be the original problem, but maybe this person has other issues like uveitis or had multiple eye trauma that can also lead to glaucoma. And in the second question is about research.
Research for normal pressure glaucoma.
Right. The question about normal tension glaucoma is such a big topic because, as I mentioned, the NTG patients, they will have glaucomatous damage, even the pressure is well under 12, under 21. And I've seen patients progressing with a pressure under 12. And often in these cases, it is believed that for some reason, their optic nerve is very sensitive to pressure. Even a normal pressure is damaging enough for them. And there are multiple papers talk about neuroprotective factors or maybe the lack of in these patients, or there's also research showing that it's the structural changes of the lamina cribrosa that predisposing this patient to normal tension. So a lot of research in this area. However, the solution remains the same. That's keeping the pressure at bay, keeping a pressure that's low enough to prevent progression.
Whatever that happens to be for an individual.
Exactly.
Cindy, the question about people with a family history of glaucoma who've had laser eye surgery, and I'm assuming this is to correct for spectacle wear. Do you feel that there's an increased chance of developing glaucoma?
Katie, I think that's an excellent question for a number of reasons. And again, we're assuming it's for people having the laser eye surgery to reduce their dependency on glasses. My answer to that is, and I think Dr. Schlenker already alluded to it, the laser eye surgery itself to correct glasses does not increase a risk factor for glaucoma. There's been no link, but many people who have laser eye surgery may be nearsighted. And we know that myopia or nearsightedness in itself is a risk factor for glaucoma. So it's not the surgery per se, but it's the predisposing condition that led them to have the eye surgery. And the thing where sometimes people get mixed up about this, for those of us who have had our eye pressures measured, we know that we measure it through the front window of the eye called the cornea. So an instrument comes in and it touches our cornea, and we use our machines to measure the pressure. And one thing we know about laser eye surgery, the most typical type, is it changes the thickness of that front window, and therefore it alters the number that we're getting. And nobody quite knows the significance of how that's altered. So in some respects, it makes our jobs as eye care professionals a little bit more tricky, because I think then we have to depend more upon all the other things that we measure when a patient is compliant, right? But Dr. Cho, compliant and come to their eye exams. So in my opinion, if you have a family history and you've had laser eye surgery, the best thing you can do for yourself is go to regular eye exams, and then your eye care professional can use all of the information they collect when looking in your eye, doing all the tests to help determine if your glaucoma is stable or not. So the surgery itself is not the problem, but it's all the other parts around it that can put you at increased risk.
Yeah, thank you. It's never an easy calculation to make. One question here on the chat is asking, is it important to have your eyes dilated at the doctor's visit? If so, how often? It's definitely important, but it doesn't necessarily have to be done every time. It depends on the reason for the visit. If there's a diagnosis of diabetes, then the back of the eye should be examined at least annually. For glaucoma, we could do a lot with our scans nowadays, which don't replace looking at the back of the eye with our own eyes, but it adds extra information and can be done without dilating. So often that might be done instead of a dilated exam every visit. But having the back of the eye inspected, not just by a machine, but by a doctor from time to time is a good idea. And another question about interactions between doctors and or different specialties. If someone's been prescribed something like a calcium channel blocker for high blood pressure, should the family doctor talk to the ophthalmologist? Matt, what would you tell them?
Yeah, there's been some kind of emerging research on this, and the problem is it's very hard to study. We have larger data now, but the problem is none of these studies have been randomized. So, for instance, half the patient in randomized fashion getting the calcium channel blockers. So there are association studies. So there may be an association, and there may be, if there's another option other than a calcium channel blocker to control, whatever systemic condition is, such as cardiovascular issues or blood pressure, could consider one else. But I don't know if there's enough evidence, and we always have to remember, as much as the eyes are important, I'm biased. It's life first, and then eye. So we do have to take into account that keeping the rest of our body and our perfusion of our eye is important as well.
And Katie, can I just add to that?
Please.
Sorry to interrupt, but this is one of my little passionate areas of interest and why the Glaucoma Research Society and what it does is so important, because Dr. Slanker just mentioned the research. We know from the older population studies, before the type of ICES research that Dr. Cho talked about and Dr. Slanker, that certain types of blood pressure medication, certain classes actually put the patient at increased risk for glaucoma, while others were found to be protective because there's calcium channel blockers, something called thiazide diuretics, beta blockers, and angiotensin converting enzymes and blockers. So this is why research is so important, because wouldn't you agree, Dr. Schlenker, years ago, we would just look at huge populations of patients and look for those associations. But now that we have larger data sets and they're electronic data sets, we're probably in a better position than we were 10, 15 years ago to answer some of those questions. So I think the type of research that actually Dr. Cho presented today is so important, because we know there's something there, but there's still a lot of research that remains to be done. And that's why the Glaucoma Research Society is so important to all of us.
Exactly. Ellen, there's a question here, which coincidentally we chatted about via text earlier today, which is, with some medications being unavailable in Canada, hopefully temporarily, is there any way to get the medications in from the US?
Yeah. So I have a few patients who spend the winter in Florida, and when they go, I give them enough prescriptions, but sometimes they do run out, and they tell me that they have to find an ophthalmologist there to see them and prescribe the medication because our license is only active in US. So
Only in
that's
Canada, I think you mean.
sorry, only Canada, in Canada, of course. So that's why I always tell my patients to bring enough medication and just emphasize, if anything goes wrong, you run out of drops, do you have a eye care professionals in US to see you? Yeah. So unfortunately, if you want to obtain medication from down south, that you need to find someone to prescribe it.
Exactly. Yeah. And what about, speaking of medication, Cindy, what about the future of depot type medication?
Yes, as you know, so all of us, for all of the people out there listening to us speak, all of us go to meetings quite regularly, national meetings, international meetings, and we've been hearing probably, I would say, especially Katie, we're a bit older than you, Ellen. We're a bit older than you. We've been talking about depots now for about 10 years from what I can see.
Easily.
They all have been investigated, and we understand why, because of what Dr. Cho talked about. I mean, compliance and persistence and adherence are challenging for patients. So wouldn't it be great if you could put a little pellet of something inside your eye, or around your eye or in a little container in your eye to dispel that medication. So there have been studies, there have been advancements, but unfortunately, they really haven't reached prime time because, first of all, it's very expensive to bring them to market. They have their own sometimes complications and side effects, believe it or not. Like they're not completely free of complications, and nobody yet has shown that they're necessarily overall better to warrant the cost. And unfortunately, in a public healthcare system, the thing about glaucoma care is it's considered by the Canadian Health Act as being medically necessary. So that means that patients really can't pay out of their pocket for some of these advanced technologies. But at the same time, the cost of these advanced technologies are so expensive, it makes it difficult for the government to make them available because they're not necessarily any incrementally better than what we already have. So the answer is there has been some advancements in types of depots. They're out there, but it's been so challenging to bring them to the patient in a publicly funded healthcare system. I hope that answers the question.
There was one that I had the privilege of doing some of the preclinical or the not preclinical, but the research for licensure. And it was a depot that was supposed to go in maybe every 4 months, every 6 months. And it got approved in the States for one-time use only. So why bother if you're only going to be able to put it in once in a lifetime when this is a lifelong disease?
And that's the thing, Katie. Intuitively, it sounds like a great idea, but when you look at it, it's not free of something the patient has to do. It's not free of complications and side effects. So again, in a judicious look at the evidence and the science, it really never got to the point that it has replaced what we're already doing.
Yeah. So there's another question about, Ellen, I gather you're typing an answer to the question about glaucoma and poor blood flow. Perhaps you'd share it with everyone.
Yeah. So similar to the question I answered before, so definitely there are a lot of study about, what makes the optic nerve more susceptible to glaucoma, right? So what makes it so susceptible to a normal tension? Part of the answer is also blood flow. It believes that sometimes there is hypoperfusion of the optic nerve. And these neurons are very active. They work 24/7 nonstop, so they cannot be suffocated. And that's why sometimes when patient has another issue, for example, optic nerve drusen, a little calcium rock in your optic nerve, I ask the patient not to take their blood pressure medication at night. I encourage them to take it in the morning because when your optic nerve is already, a bit jammed by that little optic nerve drusen, presumably the blood flow is not as strong as those patients without the optic nerve drusen. And by the same token, when patients have normal tension glaucoma, I also ask them to take blood pressure medication in the morning. Sometimes patients have glaucoma and other type of optic neuropathy, like optic neuritis and whatnot. In those cases, I get referral from the neuro-ophthalmologist, and my answers always be because the optic nerve is already under pressure from the inflammation of your disease, might as well keeping the pressure a little bit low as well. So if someone having a pressure of 23, in our study, we may or may not treat that 23. But if this patient also has other type of optic neuropathy, I tend to treat such patient. Would like to hear you guys are senior than me, would like to hear what your take on this.
Well, can I just say, I was actually going to ask all of you a related question, and I really want to hear from Katie and Matt as yourself, Ellen. We now have an advancement diagnostically known as OCT angiography.
Mhm.
There's been a lot of talk. So it's a type of a retinal nerve fiber scan that actually measures the blood flow. And it's been an advancement. It's been talked about a lot in the research realm. Have any of you used OCT angiography now on your glaucoma patients?
I haven't. I have the machine, or the machine that I have has the capability, but I don't know what it's measuring. I don't know whether it's telling me anything useful for predicting the future or if it's merely giving a different way of describing what is going on currently or looking at damage that's already occurred. So I need the people who are doing the research to show me where it fits into my decision making, rather than just doing it for the sake of having a new toy to play with.
Yeah, I do order it on occasion to try to use it because I have hope. Just like for the some of the sustained release injectable medications, I think I have hope. I agree with what Katie said. You know, vessels and nerves are friends. They travel together in the, you know, in the retina, and we don't sometimes know which one went first, but they seem to go together. So there probably are some, perhaps due to perfusion or vasospasm, where it's actually the vessel that's caused the problem. And then other times it much more, maybe more of a nerve issue. And obviously eye pressure pressing on the rim of the optic nerve is clearly not helping either of these. So I hope someday we are using angiography. It may be an earlier detection tool for some types of glaucoma. But it's another shout out to why we need to do more research and better discovery in this area.
Helen, you did a lot of work with the team in Dalhousie who are very key players in the imaging and glaucoma world. Do you have any insights to give us?
So actually, we were just when I was a fellow, we were just talking about that, and they're trying to get the machine's quite expensive, right? So they're trying to get that machine into their institution, and they are a group of five mentors working closely with each other. So for them to have a large scale clinical study would be quite possible. So I think they're looking into that, and I agree with you. I think blood flow and neurons they're so tightly intertwined with something that we should definitely look into. And I'm also hoping to use it in my future practice. But again, price at this time seems to be quite high.
I think the answer to your question, Cindy, is stay tuned, but it's not prime time yet. So we have just a couple of minutes more. One, I think, quick question is eye blink exercise a right thing to do? Matt, your thoughts?
So was that eye blinking?
Eye blinking or eye exercises?
Yeah, I mean, I'll comment on the blinking. I think the important thing for blinking is there's an epidemic of dry eye in our society. And then when we put in our drops, it doesn't help. Uh, the drops can be like, you know, salt on a wound if you already have some dry eye. So I encourage all of us, such as those of us, like all of us watching the screen right now, we have to remember to take little breaks. We're staring at screens a fair amount. I'm staring through a microscope, a slit lamp on a day-to-day basis. So I think that's where blinking is important. I don't know if it's related to glaucoma, but it is related to your ability to tolerate some of your treatments. Uh, if the question was about exercise, I don't think we're aware of any exercises to the eye that are going to modulate your glaucoma in any way. And this too is where we need more research. Glaucoma can be a very disempowering disease. I think one of the main benefits of the drops is that someone feels like they're actually doing something for their glaucoma because there's just not, you know, we've talked about today, you know, does the yoga matter? Does your sleep position matter? Does a calcium channel matter? They all seem to be kind of small things in the grander picture. And many of my patients, I have to say, you've done nothing to bring this onto yourself. Absolutely nothing. And there's also very little you can do other than follow, you know, our treatment recommends, which are regimens, which are not perfect. So I wish I had better answers for that, but that's kind of where we stand.
Okay, well, I think we've managed to tackle most of the questions that have come through, and some of them are mildly duplicated. So I would like to turn this back over to Tom and Jim Parks to wrap the rest of the evening up. Thank you for participating in the panel. I enjoyed hearing everything that you all had to say.
Okay, thank you very much, Katie, and all of the rest of the panel. That was a terrific question and answer session. I think we got to pretty much all the questions that came in this time, which we don't usually achieve. All right, I'm going to just give me a moment to figure out what to do next. All right. I'm going to I'm going to bring us back to the presentation. And next up on the agenda will be Jim Parks. There you are, Jim. Okay, I think there you are. Just a second. Okay. Hmm. Do you see the there? Do you see the main? I see your face. I think you're ready to go. Just a moment.
I'm just waiting for your final slide.
There you are. Okay, okay, Jim, you have the floor, and it's the slide deck should be showing the presentation for Dr. Zhu.
That's right. Thanks, Tom. Well, it's my privilege to award the certificate of appreciation to Dr. Zhu. I found that very interesting, and being a prolific drop taker, I hope I'm being both persistent and adherent, although I'm not sure I'm in any of the statistics. So thanks again for your very informative and helpful presentation. Just a final few comments to thank everyone for joining in and invite you to join us again next year, if not sooner. Another invitation to sign up for our website and our newsletters if you haven't already done so. And sorry, having a senior moment. Well, I think that's it. Again, just a sort of a plug in addition to what Tom said, and I think we continuously say to everyone every time we have a chance. The society cannot function and cannot make grants unless it has money. So it's the age-old question of how we generate enough revenue to make all of the grants we would like to make. So again, any financial support that any of you or others can provide would be very much welcomed. And again, just one final comment to echo Tom's comments about our walk for research on Sunday. You can go on the website and look that up and see how you can contribute to that as well. So having said all of that, I will again thank everyone for attending. I hope you found the question and answer session helpful. Thanks to all of our panelists who did a great job as usual in trying to deal with all the questions and getting us in on time. So on that note, I'll just wrap it up and say good night.
Okay, Jim, thank you very much. And thanks to everyone for attending our annual supporters meeting. I hope you have a great evening. I hope the Jays go all the way and win the World Series this year after 35 years. And we'll see you next year. Bye for now. Let's see if I can.